All right, another day, another show. It's time for some pre-cows. Emerson, what's going on today? Or,
Well, we've got a great guest, but we've got a problem, man. Our third wheel has come off. I don't know how we're going to make it.
hey, that is what is going on today. I was trying to figure out why the screen looks a little empty today. So,
It
yeah.
is. It's a little nutty. We're sorry to say that Robert is tied up today, but we're going to try to carry the torch the best we can.
All right, and talking about best we can, we have a doctor to the stars, I guess. He has concierge medicine that he provides or sleep therapies to his patients, Dr. Anil Rama, based out of California. And it's I had a short conversation with him earlier, and I know you were on the email threads, Emerson, but he seems to be a very fascinating guy, and the stuff he does seems to be very fascinating. And I think it's going to be a fun conversation with
Well,
him.
I think so too. Reading through those notes and in our conversation about him, he's able to think outside the box.
Right.
And that really is going to provide some fascinating conversation. I look forward to hearing what he can do differently because concierge medicine is so foreign to so many people. But in the market he's in, it certainly fits. And I'm excited to see what he has to say about where he's able to take his patients and what he's able to do for them that other doctors simply don't have time to do.
And I will say this, that in terms of medicine, you're right. Most of us do not have the concept of that, and a lot of people think it's only for people that are have really, really big means to do these kind of things. But he does have options that are affordable to almost any category. I will say I have a friend here in Houston that does concierge medicine, and she's board certified in sleep, and she's internal med. And I will tell you, it's extremely affordable. These are for these patients that do not want to deal with insurance and say, I want to take care of myself the way I want to take care of it, and they look for a doctor that way. So it will be interesting to hear what Doc has to say.
All right. Sounds like a great conversation.
You ready?
Yeah, let's do it.
All right.
Lights on.
Now, a word from our sponsor, Medbridge Healthcare. Medbridge Healthcare is a leading provider of sleep lab management services and home sleep apnea testing. Medbridge partners with hospitals, healthcare systems, and medical academic institutions to offer comprehensive, fully integrated services for sleep disorders. Welcome, everyone, once again to another episode of Sleep Tech Talk, the sleep podcast, with your hosts and friends, Emerson Kerr, Robert Miller, and me, Dr. Gerald George Mannikarote. Folks, once again, as always, we bring exclusive content just for you and lots of fun, lots of information. And once again, one fabulous guest. Before we get started, just want to say thanks to all of you for making our show so popular. The numbers just keep going up, and that's because of you. We can't thank you enough for that. So please continue to like, all the subscriptions, and most importantly, all the shares that you've been doing. It's because of you we've been able to get into success. And because of you, we've been able to provide more content and more exciting guests for you. Huge shout out to our sponsors, because without them, we can't keep doing what we're doing. And we thank them so much for that. With that being said, let's talk about our first guest today. Today we have Dr. Anil Rama, based out of California. And Dr. Rama brings a very unique approach to the diagnosis and treatment of sleep apnea and other sleep disorders. But I think what's more interesting is his neurological approach, which is very different from what I've come across. And also, the other side of it is the way he looks at patients and also the type of patients that he gets into his clinic. So, Dr. Rama, welcome to the show. And why don't you tell the audience a little bit about yourself?
Well, thank you, Jerry, Emerson, and Robert, who's not here. I appreciate the opportunity to share my viewpoints. No, I run a small private practice, concierge private practice, and I'm faculty at Stanford and as a volunteer faculty, and I've been there for 20 years and still write papers and articles. But in my private practice, I'm allowed to really explore. And because I'm not insurance-based, I can actually test for different things and do different things that maybe the insurance world would not reimburse. So anyway, it gives me the opportunity to really explore, and my clientele will pay. And having said that, though, I will say that I have a lot of mostly ordinary patients too that are willing to pay for, just better understanding of what's going on and guidance. But yes, we do have some of the products that we're using. I can tell you that some of their C-suite see us. But in any case, how would you like to get started?
Well, I think one quick question for you, Doc, is one that we like to even discuss is how did you get here? What led you into sleep, and especially into this unique practice? Because I think that would really inform our listeners on some of the things we're going to talk about a little bit later.
I went straight from residency into the corporate world, and I set up their entire sleep program. Spent 20 years there, but to be frank, things were being cut. Revenues were going down and reimbursements going down, and whatnot. And it seemed like every single year they were cutting. Hey, we want you to see 1 patient an hour. Hey, 2 patients an hour, 3 patients an hour. And then at some point it would get down to 6 minutes, and it was ridiculous. And it was very utilitarian. We want to do the absolute minimum possible, get them in and out. There's no time to, you have sleep apnea, here's your CPAP, goodbye. That's it. And, we don't want to explore, ask about anything else. And it just became less and less interesting to me. And I was yearning to spend that, like we do 2-hour initial consultations with our patients. So I was yearning for that more personal, hands-on, boutique, let me guide you through treatment. So anyway, that's what basically led a frustration with what's happening. And honestly, even now, if you look at it, I think reimbursement for sleep practices are dropping by Medicare every 2% a year or something like that every year for the past few years, while costs are going up. And what that means is you're going to have less time with the patients. You're going to have to see more and more people. But fortunately, I can avoid that now. But it would have been worse, I think, had I stayed.
Can you talk a little bit about your approach of, like you said, you don't want it to be just, hey, you got OSA, here's your CPAP, see you later, as opposed to what you had told me when we had our initial conversation about OSA is a traumatic brain injury as opposed to just a quote unquote breathing disorder. Could you talk a little bit more about that, please?
It might be hyperbole, but the reality is that every drop in oxygen, every arousal is like a little mini concussion to the brain. And over time, it degrades the brain. I think, and that's how those medicines, Sunosi and modafinil, came out. They look for residual sleepiness in people with sleep apnea. That's what it's FDA approved for. But no one's ever really able to capture it. So we run this brain map, and it shows the hidden order of the brain. Just like you have the horizontal thirds of the face, the vertical fifths, there's an order to the brain. And I think once you can, demonstrate what that degradation is, and then your goal is to actually, resolve it. There's always neuromodulation, and you can always restore the brain. So I think a couple of things. Number one, like I said, in the traditional world, you have sleep apnea, here's your CPAP, and you're done. But if you really ask those patients, why do they come in? They came in because they're anxious. They came in because they're depressed. They came in because they had inattention or lack of focus. They came in because they have brain fog or forgetfulness or fatigue or sleepiness. But if you really assess them after the CPAP, are those things better? I mean, they're most likely still a little anxious, a little depressed, a little ADD-ish, a little forgetful, a little brain foggish. Their sleep isn't as perfect as, not perfect. They're still maybe waking up to use the restroom, but not as much. And the reality is that when you hit, like I said, those mini concussions, when you cause the damage to the brain, it's like my scar here. I cut myself, the body heals, but it's never as strong as it once was, right? It's always a bit weaker. And the same thing with the brain. The brain will heal. Once you stop the insulting factor, the brain will start healing, but it never goes back to the way it formerly was completely. And how much it does varies by person to person. And so I feel like there's two aspects to sleep apnea. Number one is stop what's damaging the brain, which would be CPAP, oral appliances, surgery, expansions, advancement, nasal surgeries, myofunctional therapy, nasal sprays, allergy treatments, whatever. All of those things in that whole universe ecosystem is to stop the damage. But who is spending even 1 ounce of time on restoring the brain? Nobody. And so I think that's what makes our practice unique. How do we restore the brain? And we use a combination of well, everything you do modulates the brain. Everything you eat today, your exercise, what type of exercise you do, what the medicines you take, and things like light therapy, exercise, and also like we do also things like TMS, hyperbaric oxygen, different things. We can modulate the brain and try to restore it. And it's maybe a little bit too much for our short talk, but the walkaway point is that we want to stop what's damaging the brain. And I think everyone's familiar with that, but we also want to talk about restoring the brain. And this is why we work with, many of our referrals are people with mental health illnesses, neurologic problems. We work closely with the orthodontists and dentists. So our patients come from all over, and we treat them holistically. We don't stop with just the breathing. We actually want to restore that brain, which means we become their de facto psychiatrist, their de facto neurologist, and we guide treatment from A to Z.
You're right. When you think about the journey of most sleep apnea patients, it's the cause and effect, but the effect is often so dialed in on cardiac, is it the hypertension and the diabetes and that sort of thing. You really don't hear a conversation like we're having. We're talking about brain function. Now that you're in this space and you're evaluating this, what are you seeing on the other side of it? Now that you've got this focus and at least for your patients, how do you measure success with patients from a neurologic standpoint?
So I try to be as objective as possible. So our practice is highly based on testing. So we run the brain map. And like I said, just like I can see, you can look at someone's face and you can see if the horizontal thirds are there. You can see if the vertical fifths are there. You can see if they have a narrow palate. You can see it, but you can't see the brain. But with a simple brain map, you can see it. It's obvious there. And so our goal is we monitor it. We, hey, come back, do CPAP for 3 months. Let's come back and repeat your brain map. Let's see if it looks better. Let's see how much you've modulated. Oh, it's still not there. Hey, let's try a stimulant agent. Let's see if we can reduce some of the delta and theta. Let's move things over. Let's stop your Neurontin. Let's stop your antidepressants. Let's switch it to this. Let's try the TMS. And so, but after each major intervention, whether it's surgical, medicines, or other, treatments, we just repeat that brain map, and the goal is to optimize it.
Are you a sleep tech looking for new opportunities? Well, Medbridge Healthcare is one of the largest employers of sleep technologists, and they are growing. If you are a sleep technologist interested in a new position, potential paid relocation, or looking for a career advancement, consider a career with Medbridge Healthcare. Now back to the show.
So I find it really fascinating what you're talking about you establish this baseline testing and then you, like you said, monitor it. When you look at what is traditionally done at the sleep physician's level, and no disrespect to sleep physicians because that's the space we're in, but it's a little more rudimentary. We look at, like you said, once the evaluation is done and if there needs to be any specialists brought in, they do that. But however, with CPAP, it's more of, okay, 30 days, you see if the patient is adherent to therapy, and then every 3 to 6 months, they look at the CPAP download, and that's about it. But there's no monitoring of this piece. Do you correlate the CPAP usage to that, to the brain mapping that you're doing, as well as the other testing?
Absolutely. The CPAP about 80% of the time improves the brain map, but it doesn't normalize it completely. And that's why, you just have to ask. I think that's the question. You just have to ask. No sleep doctor has the time, or sleep practitioner has the time. Are you anxious? Are you depressed? I feel like if you really ask, you'll find out that most of your patients are on some type of antidepressant or on some kind of medication for a sleep, like a hypnotic agent, or some type of a learning agent, whether it be coffee, just multiple times a day. So you just have to ask. So that's one point, is that you want to do the testing and then follow along. I think the other major point I want to just pivot a little bit is that everyone is also, I'm very macro oriented. Everyone's very focused on sleep apnea, sleep apnea. Well, we know sleep apnea is a breathing problem, right? Well, guess what? Any breathing disorder that you have during the day, any breathing gets worse at night because you're recumbent, because the muscles relax, because everything slows down, and you're more likely. So if you have a breathing problem at night, I can guarantee you, we're just seeing one part of it. You're not stepping back. What you'll notice is that almost everybody has a daytime breathing problem, and that breathing problem gets worse at night. And it's that breathing problem at night that we're testing and diagnosing and treating. How many practitioners do you know out there, anywhere in the world really, that's focusing on daytime breathing? And that's the reality. So we do something called rhinomanometry, and it measures nasal resistance and flow through the nose. You close one nose, we measure the nasal resistance. We close the other nose, we measure the nasal flow and resistance. And people don't know anything. Like how you're breathing is what you're used to. Emerson, what you're breathing is what you're used to, right? But you don't know if it's low or not. And sometimes we'll test people and they're 90% below normal or 80% below normal, and they have no idea. And so I tell them, yeah, you got sleep apnea, but you have a 24-hour-a-day breathing problem, and you can fix the apnea. And they're like, well, how much better will I get? Well, if you use CPAP, you sleep, let's say 8 hours out of 24 hours. I'm expecting, let's say it works 90% effective. You should expect a 30% improvement in your symptoms. Why? Because you didn't fix the daytime breathing problem. You're still breathing through a straw. If you look at the data, in people with sleep apnea, the genioglossus muscle is more active during the day. The tensor palatini muscle is more active during the day. You're working hard to breathe during the day also. And and sometimes you can even feel that in the antegonial notch. If you got a big notch here, that's basically parafunctional muscle activity, warping the bone by just over time trying to keep that airway open, just attaching to it. So in any case, I think the two broad points are that sleep apnea is a traumatic brain injury, and you want to not only stop what's damaging the brain, but you want to look into how to actively restore the brain. Also, you don't want to step back and realize that it's basically a breathing problem, and you have to address the daytime breathing problem as well. And that's when you're going to get, once again, we fix improve their daytime breathing problem, and we can see the brain map improving. And so you really have to step back and see the whole picture.
That's beautiful. When you talk about that, I'm thinking of some of the newer data on endotyping, because that airway compensation is one of the 4 major endotypes when we think of sleep disordered breathing. Something I'd love to just take a step back on is you're doing something unique, especially in sleep, and that is you're doing type 2 testing. By having the home sleep, you're not really doing a home sleep test, you're doing a sleep test in the home. And I think that's very different from what we see. One, because insurance typically drives the typical sleep apnea test. So full disclosure, I work for Knox. So I'm asking this question not only as someone who's interested from an industry standpoint, but as a clinician. How is that type 2 at-home polysomnography working for you? And can you walk us through that process for our listeners? Because it's a growing part of sleep. We're just seeing in Quebec, Canada, that it's been accepted in that province. And I imagine we'll see it more across Canada and the United States. But if you could give us a snapshot into what that looks like, because I think it's a mystery to a lot of our listeners.
So I'll just say there was no paid promotion or anything.
No,
I
not at
Emerson,
not
I
a
don't
bit.
even met Emerson until a couple of months ago.
Thank you
We've
for
been
saying
using
that.
the Knox A1. We selected it. We've been using it for about 3 years now. And the reason why we're using it, there's no other product that we can use to do this. I mean, it's the only product out there. When it came out, we're like, yes, yes. I was thrilled with it. I don't think anyone else realized how good this was, right? But we were able to do sleep studies, comprehensive laboratory level quality in the home. And we do not only PSGs, we do CO2 monitoring, with the CU add-on. We do multiple sleep latency tests, everything in the home, and even titrations. So the reality is that, but we do it a little bit differently. I think some of the new practices right now are having the technician, and I'll tell you what we do. In our system, the technician goes to the person's home and hooks them up head to toe, and goes around 7, 8 p.m. or so, takes like about 45 minutes to an hour to hook up, and then leaves, and then comes back in the morning around 6 a.m. and to pick up the equipment. And so the patient is with the Knox equipment, they're free to drink, they're free to eat, they're free to walk, and it allows that. There's nothing attached to them in terms of attached to the wall or whatnot. And in terms of success rate, we only do one per night. We're boutique, right? So we do one per night, 7 nights a week. But we get about one failure a year max. That's it. And so it's very rare. And we always repeat the study for free if there's a failure. But I can tell you, we would actually be, we're losing money. But the reason why we can say that is because it's so infrequent that it fails. And we're super happy with the results. It's indistinguishable from a lab study. We can add a camera. We can add the CO2, as I mentioned. We don't do transcutaneous. We only do end-tidal. But anyway, and the patient satisfaction is just off the charts. They're really happy. They get to sleep in their own homes. But I think the way most centers are doing it that I'm aware of that are starting to do it now is just picking up now. I think they're having them come to the clinic at around 5 p.m. and hook them up there, and then they send them home, and then they come back the next day and drop it off. I think the only issue with that is that you got that equipment on for a long time before bedtime, and I don't know how successful that would be. But in any case, that's how we've been doing it for 3 years now. The patients are very happy, and
Well, if
and
I
the
can ask you
results.
one question, I think when you hear people talk about this, and we went through this with home sleep apnea testing too, is what are we losing, by doing it that way? What do you feel like you've gained in being able to test the patient in the home, especially when you start talking about the daytime tests like, an MSLT or MWT or something like that? What do you feel like you gain from having the patient in a normal environment versus in a sleep center?
Like the ideal sleep climate is one that you would be sleeping in a pod, and in that pod it would be temperature controlled, climate controlled, humidity controlled, moisture controlled, whatever. Every single aspect would be controlled. When you go to a lab, I mean, sometimes it's dry for the patient, sometimes it's too wet. The bed is not the same consistency. It's hard or it's soft, right? The noise, the light that comes from underneath the little space underneath the door can be bothersome. Anyway, the ventilation, the fans, all of these things affect your sleep, and all of these things change the environment. You are drastically taking someone out of their natural environment when you put them in a sleep study. It is 100% unnatural. And doing it in your home is 100% natural, with the exception of the equipment. And so I think it's not even, I don't think you even understand it's even comprehensible until you don't do it. Like doing it in a lab, yeah, I mean, we may eventually have one bed in the lab, but we are going to absolutely only dedicate that for people who just for some reason just functionally can't do it at home, but we do it in hotels. We do it everywhere. I mean, anywhere that, and people fly in and they stay in the hotel, and we do it in the hotel. They get a corporate booking rate because we have these different people staying at the same hotel every time. But anyway, so answering your question, you do gain a lot. you just have to try it to see, but it has to be done right. You know, the problem with industry is that, you know, they're going to make you hook them up at the office. It's going to go home. You're going to lose a lot of sensors. And, you know, it's not, it may not work out as ideal, because in the end, you have to have the data too. It has to be very accurate. Because we review each study with the patient. We go through the raw data. And if it's not good, if I'm missing channels, I can't hide it. Does that make sense? So they're going to see everything, and we go through line by line with them so they really understand it, not just the report, but the raw data.
So, Doc, you know, we are getting close to time, but I really want to touch on the therapeutic side. You talk about multifaceted approach to the therapy, and when you were showing the occlusion of the nares when you know, the rhinomanometry, I was thinking of pranayamas and things. Do you, and your holistic approach, do you use anything like that, or what other therapies do you use for your patients?
You know, so we're always trying to curate what's best for the patients. And I think that's what they rely on us for. There's so much out there, you know, that in the sleep world, there's so much, but what works, what doesn't. So we constantly buy things, try things, learn things, and then put it against our benchmarks. Hey, does it improve the rhinomanometry, the flow and resistance? Does it improve the brain map? Does it improve the tone? We measured muscle strength in the mouth with the IOPI. Does it improve the muscle strength? Does it improve? And, you know, and for that reason, we just, you know, we do TMS. We send people for hyperbaric oxygen therapy. And like, for instance, what are we testing now? I have this capno trainer that I'm going to be testing this weekend, right? And there's a theory that, you know, like, there's a subset of us that are hypocapnic, meaning our CO2s are below 35 to 45 at baseline. If I put it on you right now, you'll be at 32. And if that's the case, the Bohr's principle, oxygen binds tighter to hemoglobin. You dispense less oxygen to your brain and other parts of the body. You go into a fight or flight response. So you get the brain fog, the anxiety and whatnot, right? Is that true? I don't know. You know, ask me in a couple of weeks or a month after I go through this and try it out, right? Is it real? Is it real or not? I have no idea. And so if you see it on my website, offer it in the next month or two, you're going to know it's real. If you don't, then it's just something I tried and whatever. So we curate things. So yes, the answer to your questions, I haven't looked at is it pranayara, prana breathing, whatever. And I haven't,
You know what we're talking about, right? Yes.
yeah, but I am looking at breathing in terms of hypocapnia.
Good deal. Doc, we are definitely out of time, and we thank you so much for this. Where can people get more information about you and the clinic and the work that you're doing?
Oh, well, I mean, the website's probably the easiest, www.sleepandbrain.com. Sleep, and then the and is spelled out, brain. I think we came up with that name because what do we do? Well, we work on sleep and the brain. I think a better title might have been breathing and brain, but that sounds awful. So we call it sleep and brain. No, I appreciate the opportunity. Jerry, Emerson, you're wonderful. And this is a fantastic podcast. And I love seeing your growth. It's amazing. And what you're doing and educating the community. Yeah, I mean, I'm just fortunate to be part of your journey.
Well, Doc, thank you so much for joining us. And it's been a really fun conversation. And folks out there, as you heard from Dr. Rama, the information, and we'll have it in the show notes for you to check him out. And everyone out there, once again, thank you so much for joining us. We thank our sponsors. Don't forget to hit the like button. Don't forget to subscribe. And most importantly, don't forget to share. Until next time, we say lights on. All right. Another show. It's time for some postcals. Very, very interesting. Would you agree, Emerson?
Absolutely, Jerry. Dr. Rama is really an innovator. Like all of our guests, is doing something that's really unique. And as we talked about in pre-cals, that concierge approach gives him some flexibility that literally other doctors do not have. And when he was able to give us a picture of what he's doing with type 2 at-home polysomnography, that was incredible.
Wild.
Because, you know, I heard, you know, a symposium on that at Sleep in Houston this past June. And it is something that's relatively new to our market, but it's one that offers a lot of excitement for patients, an opportunity for us as clinicians to see patients in the natural environment and to hear him have success with that, doing it, one every night, 7 nights a week. That's really extraordinary.
You think about it, it's kind of going back to back to the basics kind of thing when back in the day they had, I mean, this is before my time when you had home sleep studies. What it was is they would set up a patient and then run the wires through the window, and you have something in a van or
Yeah.
something that would actually record, and you have the person monitoring there. And now
Yeah.
with technology, you're able to do it remotely, but it's back to basics, right?
Yeah, it's kind of like the life's come full circle for this. But the idea that a patient could have that experience, that us as clinicians could literally see the patient in that environment. I mean, what other environmental factors could be affecting their sleep in their
Right.
home?
Right.
Maybe an allergy. I remember back when I was in the sleep lab over 20 years ago, we had a patient that brought their pillow from home. And we learned on that second visit that there were some environmental factors in the pillow that
Right.
were exacerbating their sleep disordered breathing. So even something as simple as that might be a contributing factor. But if nothing else, just the comfort of knowing you're sleeping in your house, with that kind of test has got to be so transforming for not just the physician but the patient.
I think this goes back to the two basic tenets that he was talking about, how he approaches therapy, which is this is not just a quote unquote breathing disorder, or it goes beyond the cardiac issues
Said
that
like a true neurologist, actually.
yes, exactly. That hey, it's a traumatic brain injury,
Right.
and it's a breathing disorder that may, there are contributing factors while you're awake as well. How do we treat the patient as a whole, as opposed to, okay, we'll stent the airway and we'll go on to the next patient. And of course, he can afford the time, unlike most of us in the conventional medicine space. And so, that is granted there.
Yeah, it's incredible. I was glad we were able to do it because it brought out some of that discussion, that you've heard me talk about lately at seminars on endotyping, that,
Right.
that airway compensation factor does change. They're overly compensating during the day, and that changes at night with that OSA patient. So this really reinforces that. And I think that's something I haven't thought about until today is, what about the daytime? What is going on with that patient during the day where, their breathing disorder is a 24-hour problem? And I think that's a unique perspective. And that was something nice to learn.
Well, I think it'll be interesting to find out what he does in the future, because he keeps trying new technologies and seeing how much closer and how much better of a picture he can take of his patients. So I guess we should probably check in the future with him.
He's definitely one to keep up with.
All right. Well, I think it was a good show. You ready to call it?
Yeah, it was a good one.
All right. Well, everybody out there, thank you all so much. Until next time, cheers.
Before we go, we would like to thank our sponsor, Medbridge Healthcare. Medbridge Healthcare is developing innovative inpatient, post-discharge, and population health programs to screen comorbid conditions, diagnose, and treat sleep disorders. Learn more about their innovative solutions and career opportunities at medbridgehealthcare.com. Once again, you can learn more about their innovative solutions and career opportunities at medbridgehealthcare.com.
Sleep Tech Talk is sponsored by ReactHealth. Within our LunaPAP device line, each offering is FDA approved, encompassing CPAP, APAP, bilevel, and bilevel ST models. Our thoughtfully selected array of PAP interfaces and accessories complement our LunaPAP device line while accommodating diverse patient requirements.